Hi everyone, this week we're talking about healthcare quality. This is week 12 of the course. The overview is here. We're talking about licensing, scope and causes of medical errors. We're going to spend some time talking about the standard of care, then we'll talk briefly about ERISA and some efforts to improve quality. Now, when we think about quality of care, the first question is, well, how do we know where we stand? If you're in a particular state, you may think, well, how do I know if my state offers a high level of quality of care? And how do I know where the other places, where the other states are that do a better job, or where the other counties are, cities are that do a better job? And and this is an ongoing concern in quality of care because quality is difficult to measure, involves a number of different perspectives. So, healthcare providers might have one perception of quality, and patients may have a completely different view of quality. Policymakers have one view, business people or people running healthcare organizations may have another view. So, trying to get to some point where we have good measurable standards of quality can be quite difficult and takes a long time to come up with really good measures. But one way that we can look at quality and measure quality is by looking at things that go wrong. I wouldn't suggest that that's the best way, but at least it tells us, well, here are some problems that we need to work on, and here are some things that really do impact patients that we should pay attention to. And in an older report, this report now is over 10 years old, that was put out by the Institute of Medicine called To Err is Human. The Institute of Medicine pointed out that close to 100,000 people die from medical errors each year. And here's a breakdown of some of those medical errors. So they're drug related, they're technical errors, their failure to prevent injury that should have been stopped. They even, things that should never happen, like surgery being done on the wrong leg, or the transplant of the incorrect, or an attempt to transplant for the wrong organ, and realizing that that organ is not available, and so on. There have been lots of crazy things that have happened, and these errors, of course, harm patients. And when the harm is clear, most healthcare institutions will fess up to it. But when the harm is not so clear, then you engage in a lot of litigation that can be quite costly, and that is one of the many problems that arise from poor quality of care. And that's one of the reasons that the authors of the textbook focus a lot on the legal side of quality of care, because the legal institutions or lawyers really do get involved a lot in quality of care when things go wrong. All right, another way of looking at quality of care is looking at how people rate their hospitals and with regards to dealing with medical errors. And here's another somewhat older chart here, but it's from 2000. At least it's from this century, and from the last decade, though. But it gives you some sense of kind of where we stood as a nation compared to other countries with regards to whether or not we were addressing medical errors or not. So we were really behind the curve. We were definitely behind the curve when it came to primary care docs, and that's definitely a problem. So it says our primary care physicians were not really dealing with healthcare errors as well as those in the UK, for example. The UK, which has a national healthcare system, has really extensive primary care being offered. Everyone there has a primary care physician, so they are really spending a lot of attention, paying attention to possible medical errors. And one type of error that they pick up on quite a bit is drug errors. So often when people go off to see various specialists, they'll receive lots of different drugs, and no one's really sitting down looking at the drugs and coordinating them well. At least in the U.S., that's often the case. But in other countries, the health systems have learned over time that this is a source of medical errors. This is something we can control, and we can stop. And so in those systems, primary care docs spend a lot of time looking at the medications that patients have received from different specialists and asking the simple question: are there any potential side effects that are going to arise as a result of all these medications? Are some of these medications duplicative? Are some of them unnecessary? So they'll sit down and take a look at these things in order to make sure the patient's getting the best care possible. So they respond better to medical errors than we do. In our country, we're not doing a good job of picking these errors up and dealing with them as well as other countries. Now, with regards to licensure, licensing is one way to encourage quality, but mainly what licensing does is it sets a minimum standard for various health fields. You can imagine that before we had licensing, that we had healthcare professionals who varied tremendously, and we really had no basic bar, no basic minimum standard for people to adhere to in order to determine whether or not they should be practicing in a certain field or not. Now we live in a world full of standards. There are standards for every type of health professional, from your medical technician all the way up to your neurosurgeon. So we have basic licensing standards once people are in school. We have lots of tests that people have to take, board exams, and so on. And so now we do a fairly good job, at least, of making sure that the people who are in the field at least meet some basic standard. But of course, passing a test doesn't mean that you are able to provide quality care. So some people can get over the hurdle of passing the test, but when they get out in practice in their field, they actually are not providing quality of care. So there need to be other ways to check on individuals and the type of care they're providing, and somehow encourage them to improve and increase the quality of care that they're providing over time. So licensing doesn't do it, unfortunately. So medical errors, as I mentioned before, is one of the drivers in this field, and it's one of the reasons we're focused on quality of care. This medical errors being viewed as a public health problem is a fairly new phenomenon, as your book points out. And as stated before, we have a number of people dying from medical errors, and it's actually more than the deaths from motor vehicle accidents, breast cancer, or AIDS separately. So this is a big problem. It's something we really need to do a better job of handling, and this is the reason you see so many different quality initiatives throughout the country, because our system is not providing the quality that we think it should provide, especially given the amount of money we spend. So this is one of those areas where we're spending a lot of money on healthcare, but the return on investment is not what it should be. Some of the various causes, we already talked a little bit about this, but your book lists some others, such as faulty equipment, incompetent people, of course, not actually completing a course of action that was started. Sometimes in a hospital, a plan will be made for a particular patient, but the plan will not be carried out. Same in the clinic, of course. The doctor will agree to something with the patient, and the doctor might not follow up with the patient to make sure that that course of action actually takes place. The medical physicians and I think health professionals in general are not really good at following up with patients. But good follow-up is necessary for making sure that the plan of action that you've created will actually occur. Just imagine telling a child, if you're raising a child, you tell a child to clean up their room and then never going to check and see if the room is clean. The chances are that there are going to be plenty of times when the room actually does not end up clean, and if it is clean, it probably won't be clean to your standard. It will be clean based on the child's standard, because you're not actually going in engaging in oversight. So that oversight is often not there. That follow-up is often not there in healthcare, and so that can lead to lots of problems because people just aren't really paying attention to what's going on. And of course, staying abreast of what's going on in the field is extremely important, because healthcare is constantly changing, and medicine is constantly evolving. So health professionals have to stay up to date. Otherwise, they will become incompetent simply by the fact that they're not paying attention to what's going on in their field. Now, your book talks about this notion of standard of care, and it talks about it in the context of medical negligence. So when someone is harmed by the healthcare system and they want to file a medical malpractice case, they have to go to a court, and usually have to present information in front of a jury. Of course, their lawyer does this work, and the lawyer needs to prove that a particular standard of care existed for this individual patient, given all the circumstances that existed for the patient, the type of illness they had, their age, all these various factors that need to be considered. And then the lawyer needs to show that that standard of care was breached, and that just means the standard of care was not followed. When the standard of care is not followed, and a person is harmed as a result, then you have a case for medical negligence. And so the lawyer has to go in and prove these various elements of the claim of medical negligence. And this is something that every law student learns throughout the country. It's really basic facts, and your authors are trying to communicate some of that to you. You should be aware of it. It's not something you need to commit to memory, but just be aware that the standard of care does matter. And so, if you're in an institution that's trying to improve its quality of care, one thing that the institution has to think about is, well, what happens if we get in court? How will our standard of care be looked at, and what will be used to determine what our standard is? Well, standard is usually determined by an expert witness. So it's someone who comes in and they tell the court, well, here is what should have been done. So if you have a neurosurgeon who commits negligence, you'll have a neurosurgeon come into court and tell the jury and the judge what should have been done. What was the actual standard of care for this particular patient who received negligent care, or who allegedly received negligent care. All right. Now, in the past, the standard of care used to come from a particular profession and a particular locale. And what's happened over time is that, at least in this country, our standard of care has become more national and less regional. So there were times where if doctors in a particular township in England were practicing in a certain way, but in another township they did it differently, the second township would not be taken into account. The courts would only look at that original township and say, well, how are the people practicing medicine or practicing whatever healthcare service that's being offered to the patient? How are they practicing it within that small little area? I don't need to look outside and see what other people are doing. I'm just looking only at the customs in this particular area. And that's really changed over time for somewhat obvious reasons, because often there is huge variation between these small local areas. Even today, if you look at states, we see a lot of variation in the quality of care among states. And what we want to do is try to push the states who are performing at a low level up to a higher level. So that's why we now have national standards of care. So when when an expert witness comes into court and testifies, they're usually looking at a national standard of care. And they can often point to certain textbooks or certain clinical guidelines that demonstrate what should be done, and also based on their experience and based on interaction with other professionals in their field, they can tell the jury, they can tell the judge what should have actually been done in a certain circumstance. All right, so that's generally what you need to know about the standard of care. Now, there's a concept called vicarious liability, and all this means is that if you are working for a hospital, or working in a clinic, and you are representing that clinic, then if you do something wrong, the hospital or the clinic can also be held liable for your actions. So just imagine, think about some other field. For example, if you have the garbage man come to your house and they pick up your trash and then they drop the garbage container on your car and mess up your car, right? So they put a dent in your car. Not only is that garbage man going to be liable, but the city that sent that garbage man out, or the jurisdiction that sent the garbage man out, is going to be liable. So when you go to file a lawsuit or complain, you're not going to complain to that actual garbage man. You're going to complain to the people who hired that garbage man. You're going to say, hey, you guys hired someone who was incompetent. He came out here, he dropped the can or the container on my car and messed up my car, and I need to get paid for that. You're not going to expect that that individual garbage man is going to pay you, but you are going to expect that the institution that hired him is going to pay you. So they're going to be vicariously liable. So they, as the person, as the entity that's in control, is going to be liable for their agent, and the agent in that case is the garbage man. Same for healthcare. Nurses are usually agents of the hospital. They're employed by the hospital. They're controlled by the hospital. The hospital tells them what to do. They control when they work and when they go home and so on. So they are agents of the hospital. Well, it turns out that doctors are often independent contractors. So doctors actually are not usually agents of the hospital. They usually have a contract with the hospital, and so they do some work in the hospital. They do some work in a clinic, but they determine the terms of their interaction with the hospital. So many radiologists, for example, in a hospital are part of some outside radiology group, and the hospital really is just subcontracting with them. So they're writing some type of contract with that radiology group to get a certain amount of service from them each week, and they pay a certain amount of money for that service. And the radiologists go off and do this for a number of different hospitals. So they may have multiple contracts, and so they're not employees of those various institutions they have contracts with. They're just they're essentially engaging in a business-to-business transaction. They're setting up a legal contractual relationship with them, but it's not an employment relationship. It's just services being provided for a certain amount of money. Okay, and so people who are independent contractors are not usually going to be a source of vicarious liability. So one reason that hospitals set up independent contractor relationships with doctors is that they don't want to be liable for medical malpractice. Why? Because medical malpractice costs a lot of money, and the hospitals don't want the additional costs. So they try to avoid getting involved in medical malpractice by setting up these independent contract relationships with doctors and other health providers. Now, there are times when hospitals, insurers, and managed care organizations can engage in decisions. For example, an insurer can create a certain coverage policy or make a certain coverage decision that will lead to an injury of a patient, and they might be held liable for that. So there can be corporate liability, so institutional actions or omissions. So there's sometimes hospitals will not do something. For example, they will not keep a certain area um, free of pollutants, and so therefore, someone who has allergies might be harmed by these. The pollution in the air in a hospital, for example. So there may be something they did not do, or something that they actually do. For example, they may provide certain types of food to people in the hospital, and they may actually provide food that could be harmful to certain patients, and so they may actually be doing something or not doing something that can contribute to their negligence. And some of the things that they might do wrong are listed here below. One that's fairly common is the failure to screen out incompetent providers. So if hospitals don't do a good job checking the licensing of the health professionals working in their hospital, then those individuals may provide poor care, which can lead to injury of patients. So the hospital will be held corporately liable for actually not checking the credentials of those providers before they interact with patients. Now, ERISA, we're just going to scratch the surface of ERISA. It's the Employee Retirement Income Security Act. ERISA is structured to provide federal protection to the pension system that exists in our country. It was created in the 70s. The reason it was created is because the federal government realized that a number of lawyers out there wanted to go after these pension systems with a variety of different types of lawsuits in order to try to withdraw money from the pension systems. The pension systems are extremely large. They contain billions of dollars, and anytime you have an entity with billions of dollars, then you're going to have lawyers somewhere around trying to get at that money in different ways. And so one way lawyers wanted to get at this money is by attacking the health benefits that come from these pension plans. So when the health benefits were not covering certain treatments, the lawyers would say, well, they're liable, they're corporately liable, and they committed medical malpractice, and so they need to pay out a certain amount of money. But you can imagine that if a number of lawyers are doing this, then it could potentially gut the entire pension system. And so the federal government, Congress, realized that if they were going to preserve pensions for employees, then they needed to come up with some way to protect these pension systems against a variety of different state laws that are out there. So ERISA does that. ERISA has something called a preemption clause where it prevents a number of different state laws from being used to sue these health plans um, in order to uh, withdraw money from these plans. All right, and so that's one of the main goals and one of the main tasks that ERISA carries out. And that's all we'll cover for the purposes of this class. So just know that ERISA helps protect pension plans. It also protects health benefit plans and other types of employee benefit plans that currently exist, because ERISA actually covers not only the retirement plans but the plans of current employees too. Now, the ACA, as we talked about before, has a number of provisions that refer to quality of care. And what you should know here is that public and private payers can incentivize the behavior of doctors and patients. So I'm sure you've learned from this class and you know from your own experience that depending on what your insurance pays for, you're more or less likely to demand that service. So when your insurer requires you to pay 50% of the cost for something, you're less likely to want it than if your insurer requires you to pay 5% of the cost of it, right? So your insurer can determine your behavior in that way. And it's the same for physicians. If the insurer is reimbursing physicians at a higher rate for one type of behavior or one type of service than another, then the physicians are going to go usually with the service that's being reimbursed at the higher rate. So healthcare payers, insurance companies, and Medicare and Medicaid play a big role in incentivizing quality of care behavior among doctors or providers and patients. And so the ACA has a number of provisions that are focused on trying to improve the way that Medicare pays for quality of care, and private insurers are likely to follow some of the approaches in the future. And so here on this slide, I just list a few of the things that Medicare is doing. They're improving their measurement of quality, because if you don't have good measurements, as we talked about initially in this lecture, if you don't have good measurements, then you can't go out and figure out whether or not quality of care, whether or not quality care is being provided or not. So you have to start with good measures. Those measures should be publicly reported so that the public can actually look at them and decide whether or not they want to receive health services from a hospital or a physician that's rated at a certain level of quality. And Medicare is also paying for higher quality. So Medicare has a new policy called Pay for Performance, where Medicare will pay physicians for meeting certain quality measures. So if you have a heart attack and you go into a hospital, you go into an emergency room, there are certain things that you should receive as a victim of a heart attack. And if you don't receive those, then we know you're probably not getting good quality care. For example, aspirin, oxygen, and so on. There are certain things that every heart attack patient should receive, an EKG, in order to make sure they're receiving quality care. So Medicare is now paying for meeting those quality measures, and when physicians don't meet those quality measures, Medicare will actually pay less. So that's one way that a public insurer can incentivize quality behaviors so that we'll have better outcomes in the long run for patients. And remember that all of this discussion of quality is really focused on trying to improve the health outcomes of patients. So if the quality of care is high in the healthcare system, then we know that we have to look elsewhere for any problems that we have. So we have to look at individuals or communities or environmental factors that might impact the health of individuals, because we know that we've improved the quality of care. But as stated, we still have a long way to go towards improving quality of care in our country. We face numerous challenges. Improving quality is highly complex, as you can imagine. It involves the legal system, it involves business, businesses. It involves the improvement of logistics of a variety of different healthcare institutions. And I'm sure all of you are aware of just how complex this can be, but we have a number of efforts that are pushing towards improved quality. And over time, we will see changes, hopefully, for the better. Okay, have a good week. This week, we expect you to spend most of your time working on finalizing your drafts, and next week, you're going to present your papers online to the class. All right, take care. Also, have a good Thanksgiving next week.